I am Kanika Jain. I am Associate Research Scientist at the Yale Cardiovascular Research Center at the School of Medicine, Yale University. It's my pleasure to introduce Dr. Chiadi Ndumele, who is an Associate Professor of Medicine and Epidemiology at the Johns Hopkins School of Medicine. And he serves as the Director of Obesity and Cardiometabolic Research, as well as the Director of the Heart Failure Prevention Program. He also is the chair of the AHA Council on Lifestyle and Cardiometabolic Health, and he's going to be presenting his work today at the Metabolic Disorders and Vascular Diseases session at the Vascular Discovery. Nice to meet you, Dr. Ndumele.
Yes, wonderful to meet you. Thank you for the nice introduction.
Can you tell us a little bit more about your specialization at the cardiovascular, kidney, and metabolic disease syndromes, which we are very interested to know about?
Well, thank you so much. It's really a pleasure and a privilege to be here talking about this. As you mentioned, I've been very interested in helping to develop and lead this construct around cardiovascular kidney metabolic health. And the reason for that is because, over the last few decades, we've really seen a substantial shift in the phenotype of cardiovascular disease risk. And what we're seeing, as opposed to, what I came up with when I was first thinking about being a cardiologist, like get the cholesterol right, get the blood pressure right, and stop smoking, which is all very, very important still. We're now seeing this additional layer of multi-organ complexity on top of that. A lot of that driven by excess and dysfunctional adiposity, which is more relevant in the obesity epidemic, but that as a cause of this multi-system disarray that is basically contributing to more and more cardiovascular disease risk. So if we only focus on the old traditional risk factors, we're going to leave a lot of residual vascular, cardiovascular risk on the table. So it's really an important need to shift our paradigm or how we're thinking about both cardiovascular disease prevention and secondary prevention to optimize cardiovascular outcomes in those with existing cardiovascular disease.
And that makes so much sense. And I'm surprised that hasn't been the focus till now, because we always, from a research perspective, do see overlaps between the etiology of these diseases. Can I ask how you became interested in this field?
It's a good question. And I think it actually gets to the point that you just raised earlier. So when I was a medical student, I loved cardiology, and I really thought that acute coronary syndromes were quite exciting, and there was really great science around that. But the other thing I noticed while I was doing some early research as a student was that there was this emerging wave of metabolic risk, and I was seeing the challenges that I anticipated were going to come as a consequence of growing rates of obesity, and also the fact that we were seeing disproportionate burdens of these metabolic risks in certain communities. So I saw quite a bit of opportunity for enhancing our approaches to cardiovascular disease prevention. So that really led to this initial area of focus in terms of thinking about metabolic health. In terms of thinking about heart failure and heart failure prevention, that really stemmed from some of the early work that our group did that really started to demonstrate that heart failure was emerging as this major challenge related to the obesity epidemic that was unique in terms of an independent relationship with adiposity that was really not being very well explained by some of the other traditional risk factors. So it really pointed to another opportunity both for science and for enhanced clinical care. So that's kind of what set the stage. I think today this has now become that much more relevant because we've seen shifts in cardiovascular mortality, we've seen shifts in the phenotype of cardiovascular disease, and we have a lot of emerging therapies that are very relevant to this space. So that's really, I think, kind of power charged the idea of focusing on this construct.
You mentioned the emerging therapies. I think it's obvious that a question that crops up is that how do you think about the GLP-1 antagonists and GLP-1 receptor targets? How do you think that frames in with the CKM syndrome? And
I mean, it's a great question, and it's obviously a very central therapy to be thinking about. So we have a lot of different therapies that have multi-system benefits that impact C, K, and M, have cardiovascular effects, kidney effects, and metabolic effects. But the GLP-1s are kind of particularly interesting because when you look at the pathophysiologic construct or the conceptual framework for CKM and where it starts with this kind of excess and dysfunctional, especially visceral adiposity, adiposity, ectopic fat deposition, the development of metabolic risk factors, all these central processes of inflammation and insulin resistance and oxidative stress, the development of kidney disease related to metabolic risk, and then all these forms of cardiovascular disease. It is remarkable that GLP-1s pretty much hit all of those different targets in a way that is almost tailor-made for what we should be thinking about in CKM syndrome. So I would say that they're a pretty fundamental therapy, where there are going to be some important considerations about how we target them in the population. But I do think that in terms of the science, there's really an amazing opportunity to target the root causes and the various pathologies of CKM syndrome with GLP-1s.
That sounds promising. I would be excited to see how that moves forward and how we can have them reaching the right people for the right syndrome situation, I would say. Like,
Yeah.
it is a multi-dimensional
100%.
syndrome, and we need to kind of make sure how it goes from risk management to treatment. And
Yes.
that brings me to the point that what do you think is the biggest challenge that clinicians face, and what would actually be the right clinical specialty for the patients to approach
Yeah.
if they are categorized as having the CKM syndrome?
Well, this is an important question for sure. And I think, first of all, the biggest challenge relates to your question, which is the fact that it's multi-system complexity. So you don't have patients who just have kidney disease or just have diabetes or obesity or just have cardiovascular disease or hypertension or dyslipidemia. They usually have a cluster of these various factors, and there's heterogeneity, but they're generally clustering across those. And our therapies don't just target one system, they target multiple systems as well. So it's very easy for two things to happen. Number one, it's easy for things to fall through the cracks because people say, well, that's not my responsibility. It's this person or this person or that person. So that really reflects kind of our siloed approach. And then number two, in general, there's a lot of just care fragmentation for patients who are seeing multiple different providers, especially if they're getting different messages. So I think one of the things that's going to be very important is harmonizing our clinical messages across specialties so that whether you see the cardiologist, endocrinologist, the hepatologist, the nephrologist, or your primary care physician, we're all saying similar things. And then also to have processes, we can't just give clinicians more things to do. We need to have processes in place that actually can really support interdisciplinary coordinated approaches to care. So I think that that's going to be a big focus. I'm excited by the fact that AHA and ACC are releasing clinical practice guidelines around CKM syndrome care, which I hope these are going to be major areas of focus as we're moving forward to the next stage of care for this condition.
You are definitely a pioneer in the field, and I think this would be a focus of your talk today as well, where
Yeah.
you would be talking to all of us and expounding upon how we need more attention to be paid to the
Yeah, I think
field.
that's right. So today what I'm going to speak about is kind of some of the underlying root cause pathophysiology, some of the interorgan kind of interactions that are responsible for so much of the really bad outcomes we're seeing, and then thinking more broadly about approaches to earlier detection and prevention, thinking about how we can start to tailor some of our approaches to management, and also thinking about the next steps in terms of CKM syndrome, both in terms of the clinical practice guidelines that are going to be coming, but then also in terms of thinking about the science and where we need to go from that standpoint as well. So that's the hope that I'll be able to cover today.
Absolutely. We're really looking forward to it. Also, you mentioned about the increasing incidence of heart failure,
Yes.
and especially HFpEF.
Yes.
So how does that play in? Do you feel some of the therapies or some of these management strategies that are being looked at for CKM syndrome,
Yes.
could they really limit or alleviate some of the cases for
It's a very,
HFpEF?
very important question. So this is actually going to be one of the most important, I think, epidemiologic trends and clinical and public health trends of our time. In the last 15 years or so, we've seen a complete reversal in heart failure mortality rates, and it's steeply rising in a way that is, quite concerning given the mortality associated with, and the costs associated with heart failure. And this looks to be mostly related to HFpEF. And of course, the HFpEF physiology now has really predominantly become a CKM syndrome pathophysiology, this multi-system physiology driven by excess and dysfunctional adiposity. The good thing is that most of the therapies that we think about for CKM syndrome, and including those that target cardioprotection and diabetes, obesity, and also target CKD, most of these therapies have a heart failure reduction benefit. They actually mitigate heart failure risk. So I think that there's a couple things that are going to be important. One is identifying people who are at risk earlier and basically starting to think about not only treating heart failure, but preventing the development of heart failure, but then also recognizing the importance of heart failure care in the context of CKM syndrome. So when we see our heart failure patients, HFpEF in particular, making sure we're doing systematic assessments for CKM syndrome so we can improve their outcomes.
That's good to know. And like you said, it is worrying. The trend of increasing
Yeah.
heart failure is worrying, and especially with the advent of so many new therapies and more care available, it is a frightening prospect. So I'll ask from a more personal perspective. I work on platelets.
Mm.
So where do you think antiplatelet agents
Yeah.
and antiplatelet resistance, and because they are aspirin is given out like literally candies for secondary prevention. So
Yes.
what's your view on
Oh, I
that?
think that's a very interesting area. I was actually just having this conversation with a few scientists earlier this week. And I think that we know that at the end of the day, MIs are still the leading cause of mortality. And atherothrombotic events are still a very substantial challenge, particularly in this population. We also know that even above and beyond lipid lowering therapy and even antiplatelet therapy, we are still seeing this high burden of residual atherosclerotic risk in this population that seems to be driven by a lot of the processes related to CKM syndrome. So I do think there's a world to better understand the mechanisms of residual risk, to better target antiplatelet therapy. And as you know, antiplatelet therapy, there's a plus and a minus. The bleeding is the minus, but the plus is the atherothrombotic benefit. So being able to know where we should be tailoring and targeting that is going to be helpful, but then also to develop better ways to prevent some of the platelet aggregation that's going to be more likely in this group. So I think that this is a very important area of science. I'm happy you're doing it.
Yeah, I think we are really trying to figure things out there. But as an expert in CKM syndrome, where would be the ideal position you would like to see the field in maybe like 5 years?
You know, in 5 years, my hope is that we are doing a little bit less focus on just, okay, I have this really complex patient in front of me with all the stuff, heart failure and CKD and diabetes and hypertension and obesity and all the challenges in front of me, and just, okay, I'm just going to deal with what's in front of me. I'd actually hope that we're actually starting to focus on seeing the potential to prevent getting to that stage and basically identifying people earlier in the process, which is what the CKM staging framework is about, is really identifying people early in that life course process and averting their natural history. I also am hoping that the clinical guidelines can really support more holistic care, and it's often the case that guidelines can lead to changes in coverage and practice, so I really do hope that can be helpful from that standpoint as well. And then I also hope that we have more and more structures in place to allow patients to benefit from more coordinated and collaborative care, and that we move a little bit beyond just our siloed approach, and that we're not just thinking about what's right in front of us in terms of the clinical factors in the EMR, but also the broader social context that's actually contributing to risk as well. So it's a lot, but those are some of the things that I'm hoping for in the next few years.
Absolutely. I'm really rooting for more answers and likely more questions, as is with every research and every kind of science. Thank you so much for talking to us,
Thank
and
you.
we'll really look forward to your talk.
I'm really grateful to be here, and I appreciate the conversation.
Thank you.